Hi, this is Vets4Ukraine 2022, and today is the 22nd episode of our live, the 22nd live with one of our webinars done by specialists for the vets and for the vet students and for the vet nurses. Vets4Ukraine is a group of specialists who join together, put together their forces to organize free webinars, so webinar with free access for you in order to collect donations to raise funds to support the British Red Cross to help our brother and sister in Ukraine in difficulty. So who has been connected with us last time? We have now reached the £13,000 in donation. Actually, we are over the 13,000, and we are hoping that with a special guest of today that we will reach or we will increase the collection for our friends in Ukraine. So some of you might have met him or seen him at the Vet Festival organized by Fitzpatrick Referrals. But for those of you who have not taken part of that festival, I would like to introduce you the speaker of tonight, Luca Ferasin. Luca Ferasin is an Italian cardiologist, specialist in cardiology, who is well appreciated and well known, not only in Italy, in Europe, actually, I would say in the world. And Luca will talk about syncope in dogs and cats tonight. So I think we want to introduce Luca so that he can join us. But before doing that, I would like to remind you where you can donate. There is a link, which is the, if Paolo can show us the link, is the www.justgiving.com/Vets4Ukraine. So please, if you have the financial possibility, we would be very happy if you could donate even a little amount, because every little counts, every little helps. And therefore, please click on the link and also try to share our lives to as much as you can, so that we can reach as many people as possible in order to have as many donations as possible. So don't forget, click the link, and now let's meet together Luca Ferasin. Hello, Luca. How are you?
Good evening, Daniela. Thank you very much for the lovely introduction. I need to stand properly to show my beautiful Cardiology Ukraine T-shirt.
Beautiful T-shirt. You have the flag.
And the flag on the back. Absolutely. As Daniela said, this is a very important cause. It's a very important cause because even with a very little donation, we can make a massive contribution to assist the Red Cross in this particular case, that will provide support and assistance to people in difficulty in this country during these very difficult times. And I do feel very strongly about this activity and this initiative, because I've got a lot of friends in Ukraine, and I spoke for Vets in Ukraine online because of COVID last year, and I was invited to present in person this spring. Obviously, for these current circumstances, it didn't happen, but I really hope that peace will eventually prevail, and we will see a free Ukraine once again, where people can enjoy life as they should, because nobody should be in 2022 should be living under these terrible circumstances. So thank you very much for inviting me. It's a real joy and pleasure for me to be here tonight.
Thank you, Luca, for being here. We are really pleased and delighted to have you here, and also, because you are a friend, we have nominated you like the cardio wizard in our promo in the past few days, and tonight we have started in a a bit different way, so we haven't done a proper countdown. So Luca, I was planning to launch the countdown with you. Are you happy to launch the countdown?
Sure, absolutely.
Okay, let's do the countdown.
Let's start the countdown then. Let's go. 3, 2, 1.
Hello, good evening. We've got a special message here for a very special person. Luca, the children wanted to say something, just something about you, which is a message I think that most people in the vet profession won't necessarily see, because we see you behind the scenes, we see you at home, we see you when you're happy, we see you when you're tired. So they have their own messages for you. This is Dante first.
Our daddy is a kind, special and generous person because he always finds time for us despite all the work he has to do. He plays football with us and reads us stories at bedtime, no matter how tired he is. Together we make pasta and go on special trips. He is our best friend and we love him so much.
Mattia, what are you going to say?
We love our daddy very much. He is always there for us and we have a lot of fun together. We play games together and I enjoy singing and dancing with him to our favourite music. I love our walks home from school when he buys us chocolate ice cream. He is the best daddy in the world.
I'm very, very privileged to not only be Luca's colleague, but also to be his wife and his partner in life crimes. I can speak of Luca in a special way, both on a professional level, but also on a personal level. I see him at work, I know how amazing he is at his job, how well respected and how talented he is as a clinician and as a cardiologist. He has a vision and an inspiration in our clinical work and in research, which I don't think is matched by anybody else that I know, at least not anyone that I know so well. But at home and in our personal life, I'm really very lucky to call Luca my soulmate and my best friend. We've been married now for nearly 13 years. We've been through amazingly fun times, very difficult times, and no matter what happens, he's always there for us as a family. So I just want to say thank you for being there for us, and we love you very, very much.
Ciao, Papa.
Ciao, Papa.
Oh, that was a bit unfair. I'm so emotional. Oh dear, I'm not sure I can speak now. Thank you very much.
Sweet. How old are Dante, Mattia? How old are they?
Dante is 10 and Mattia is 7.
Oh my God! I remember when they were little children.
Little boys, yeah.
Yeah. Oh my God! Time goes so fast. So. In the meantime, we have already had two donations. Thank you very much. So for those of you who have donated, I will check in a few minutes, and if I see your name, I will thank you in front of everyone. And this was the very first surprise for you, Luca. But I know a little bird told me that your children might come and say hello to us before to go to bed. So they are having dinner now. And I hope to see them. And I think we have another friend that would like to say hi to you. We are celebrating you, because we are your biggest fan. So Paolo, are you happy to introduce our next friend and guest for Luca? Hello, Stefanos. Your microphone is on mute.
Good evening, everybody.
How are you?
I'm fine, Daniela. Thank you. How are you?
I'm fine. Thank you very much. It's so nice to see you again. So really, 2 months later, now we had you here with Jackie Demetriou, and she did her presentation. Now we have you here with Luca. It's such a pleasure to see you again, and thank you so much. So, Luca, this is the surprise for you.
Oh, that's amazing, Stefanos. Lovely to see you.
The pleasure is of mine.
We are quite active on Facebook. We interact a lot. And 2 or 3 days ago, Stefano sent me this cryptic text. I didn't really now understand what it meant now. And he said, "See you soon." I said, "Well, I hope, because we haven't seen each other for a long time." So that's what it meant.
Well, hopefully we'll make a good start today. And who knows, possibly in the next few weeks, we may see each other live.
That would be nice.
It would be great.
Yeah. I'll get back to you with that. Luca is an amazing person. He's an amazing friend of mine, and you and all our colleagues tonight are very privileged to listen to him lecturing about syncope in dogs. And he's amazing. I can't say anything else. I missed the beers with him in Athens a couple of years ago before COVID. Hopefully, we'll have the chance very soon to have a beer again. Maybe somewhere near you, I think. I'll get back to you.
Great. You can come and stay with us. We always have a guest room for friends. So
and of course, since I know that you're a pasta specialist, we can have a webinar also about how you make pasta your way.
Oh yeah, I'm saying gnocchi. The other specialty, pasta and gnocchi is my specialty.
So I have the names of the donations. So Ela and Mark Overend, thank you very much for donating. This make actually your donations are making a big difference, because right now we is not a competition, but we are now at 13,130, which is more of what our friends from the neurology team have done. So thank you, and very well done to everyone. And thank you for your support, and for supporting the British Red Cross, and for supporting the Ukrainian people. Look here, Carlo. So we are having now loads of people, your friends, Luca. So
oh, Carlo, bless him. One of the best.
People are gathering.
And Stefanos, I was saying talking about traveling and seeing each other in person. So sooner or later, I will pop down to Greece, because I've never been to Greece. I will pop down and
okay. So I
say hello.
I have plenty of places to suggest.
I have just been auto-invited, basically. So okay, Paolo, have we got any other surprise for Luca, or are we able to crack on with the talk? Let me see in the comments.
Hi, I'm Joe, and I'm a cardiology nurse working for Luca and Heidi at SVCC. I've known Luca for several years now, and I'm privileged to work for him. As a cardiologist, he shows both compassion and professionalism towards patients and their carers. His passion for the job comes through on a daily basis. As my boss, he listens to me and treats me and others around him with respect and integrity. I've learnt so much from him, including the art of Italian swear words, and haven't laughed so much at work. On a personal level, I've been welcomed into the Ferasin family with open arms. Thank you, Luca, for being you.
So, Luca, do you want to introduce this lady? So,
Joe Ferasin is my cardiology nurse, and we've been working together for, can't even remember now, 5 or 6 years at least, and she's always been amazing. Well, also, since there is Carlo appearing again, bless you to Carlo is a real chef. We're talking about making pasta gnocchi. He's one of the best chefs, actually, in the Veneto region. So if you're going to visit Venice, you should go and try his amazing delicatessen. So thank you, Carlo. And Joe has been always a very, I can say faithful, because she's always worked with us for these years, and extremely talented, and she's certainly not just a member of the team, but a member of the family, as she quite rightly said in her introduction. So thank you very much, Joe. That was very nice of you. Thank you.
I must say, it's so important in the profession to have someone like the importance of the nurses, and the importance of their role in helping us in our everyday job. So it's so important, because when they work with us for so long, they really know what we need and how we work. And this is an extremely important support. I don't know if you agree. I know this from surgery. So is half of the job is done by them, and therefore I would like to now take the occasion to thanks all the nurses, the vet nurses that I've worked with in the past and in the present and maybe in the future. So you are so important and so fundamental for our job. And thank you for your hard work every day, day by day. Thank you.
I couldn't agree more, Daniela. I mean, cardiology, my cardiology service wouldn't exist without the nursing skill and attitude and the compassion that they always express in their daily activity. And so, totally agree with you. Nurses are.
By the way, this is the month of the nurses, so it's the so even more. So thank you for your hard job, and we appreciate you so much, even if sometimes we don't show this. Oh, Christina, good morning. So we have missed you in the past couple of episodes. Welcome back, Christina. So I think, Stefanos, do you want to add something? How are things in Greece? It seems that it's very hot right now.
Yes, we're around 30 degrees Celsius these days. It's very sunny. People are already started swimming in the sea. The Mediterranean way of life is coming back, and COVID cases are not so many at the moment. It seems that we're getting back to near normal.
This is fantastic news. Also here, that life is going back to normality, more or less. So at work we don't have to wear the mask anymore. What about you, Luca? Do you have to wear the mask still at work?
Yes, we do. We wear the masks. We still see clients in the car park. So we're still adopting the highest level of security. But nevertheless, we have colleagues at the moment. We got at least 3 colleagues I'm aware of that are home with COVID. So we should never lower the guard because it's always around. And it can be nasty. It can be nasty. And not just for us, but also for our pets. As you know, we were amongst the first to report symptomatic cases of COVID in dogs and cats.
So you wrote a paper about that, no? You did a research on that, yeah?
Yes, we published 2 papers. Well, one is the continuation of the other, and in our cases, they were all cardiac patients, so they all developed cardiovascular symptoms. So it was quite dramatic.
And how did you treat them?
Well, we only treated with supportive therapy because you can't really treat the virus, and therefore we just need to keep them comfortable and alive until they get rid of the virus themselves.
Fantastic job. So, do you believe you want to start your presentation, or shall we wait for Dante and Mattia? What do you think?
Well, I think they're having dinner now, so as long as people don't mind seeing these 2 children coming and interrupting the the presentation for a few minutes, because they told me earlier that they want to say hi to all our Ukrainian friends, and they want to say hi to the Ukrainian children that are perhaps not watching us tonight, but they're living with their parents who are watching us. So I think it would be nice to see what they want to say.
It's no problem. I would say let's crack on, and then.
Oh, I think they're here actually. Well, good time, right? So it's coming first. We're coming together. Come together. Here. All right. We got Dante here.
Hi, Dante. How are you?
And come on, Mattia. There we go. Both here.
Yeah.
You want to say something? Dante first. Do you want to say something to our Ukrainian friends and their children?
Now they are
Come
shy.
on, don't be shy.
Just say, God bless you. God bless your country, Ukraine.
God bless you. God bless your country.
Oh, sweet. Yeah, I want to say something.
Yeah. Okay.
Nice.
Yeah, they're a bit shy.
Yeah, that doesn't matter.
Yeah, they're thinking about children that are in Ukraine at the moment who are not as privileged as us right now, but they will get their freedom back hopefully very soon. Is that right?
Yeah.
All right, now go to bed and sleep tight. Good night. Careful. There we go, the cable. As you can see, this is a very improvised setting. I'm at home. The flag was also meant to cover the china cabinet, but it fell because attached with a bit of tape. So you can see the china cabinet behind. Right, so now children went to bed, so we can start with the presentation, I believe.
Okay, Stefanos, do we see you again, or are you leaving us now? What
No, I'm leaving. I have to go.
Okay,
Really sorry about it.
Lovely to see you. Thank you very much for coming.
Love you guys.
it was nice to see you again. Bye bye. Take care.
Me too. Bye.
Bye.
Have fun. Great webinar.
Thank you. Bye.
Excellent. Right. So, yeah, if we are ready, I can share the screen, and I hope you can see well. So I decided to talk about falling and fainting because it's one of my favorite topics. I've been studying this problem for several years, and the way I prepare this talk is by using obviously a bit of introductions every time, but real clinical cases that I've seen in the last 20 plus years, and they're all cases of falling and fainting. The reason why I talk about falling and fainting, because the word collapse doesn't really mean very much. Collapse is more a word that refers to a collapse of a structure, a collapse of a building, for example, but dogs and cats don't really collapse. That's a wrong terminology. Even in human medicine, they don't use the word collapse unless it's a cardiovascular collapse or a bronchial collapse or a tracheal collapse or a collapse of an organ. But what they do, these patients faint, so they lose consciousness and therefore they fall accordingly. So I will use these words, falling and fainting, which I believe is more appropriate than the word collapse. And here you can see that collapse really means to fall apart. So let's just talk about falling and fainting. So what are the major causes of falling? Well, syncope is certainly one of the most important ones. Syncope or fainting is loss of consciousness caused by cerebral hyperperfusion. So there is not enough blood going to the brain, and so the brain switches off for a few seconds, and then the patient comes back to life in a way. Then we got seizure, which is more of a neurological problem characterized by an abnormal electrical activity of the brain. And then we got falling due to muscle weakness, which is, for example, in exercise-induced collapse in dogs, which is another terminology I don't like because the collapse doesn't really fit. But I did study a lot this condition in dogs, in Labradors in particular. I published, and that perhaps would be another nice topic if we carry on with this activity, not for because we want this condition in Ukraine to carry on for long. Actually, we want it to finish tomorrow, but because we want to maintain this friendship and this beautiful relationship with our Ukrainian colleagues. And then we got.
We will certainly continue to do that, supporting Ukraine, but also just to help our friends with webinars. By the way, I just wanted to tell you that we have 50 people following you, so which is amazing. So
God, fantastic news.
Thank you for being with us, guys. Thank you.
Absolutely. Because they thought they were going to see Richard Gere rather than me after the introduction that Paolo made. So, right, I'm very sorry to disappoint you. I'm not Richard Gere, and I will never be as good looking like him, but I was in the Navy, so there was a real picture. I was in the Navy for 2 years, and I had probably the most terrific time of my life. I really loved it. Beautiful, beautiful experience. Anyway, other two minor causes of falling are reported. The last two posted, so muscle cramps and muscle pain can also contribute to this problem. So let's start with syncope, with the cerebral hypoperfusion or fainting. Let's see what this word means. It means a sudden, unexpected, and unprovoked loss of consciousness. So if this happens suddenly, unexpectedly, and unprovokedly, then it means is a typical syncope or fainting. And obviously, if the brain switches off, the body is no longer able to stay in a standing position, in a normal gait in case of dogs and cats, and therefore there is loss of postural control and falling. It is transient. Transient means a few seconds. This is transient in terms of time is a very relative concept, because if you ask a neurologist, transient could be minutes. If you ask an internal medicine person, transient may be months. When they say, oh, you had a short period of diarrhea for a couple of months. Well, for us, transient means seconds, because after a few seconds, these patients return to normal, so they have a spontaneous recovery, and they go back as nothing happened, unless they injure themselves during the falling, of course. But when they are recumbent on the ground, on the floor, they look dead, because very often they don't have a heartbeat and they don't breathe. And therefore, you can imagine the emotional stress, the stress for their carers, for their owners, because they think that their dog or their cat is dead. And therefore, the only difference between syncope and sudden death is that with syncope, then the patient wakes up afterwards. With sudden death, it is reversible. And I always say there are a few exceptions reported in the literature, and one is certainly the resurrection of Jesus, where he resurrected after death. But this doesn't happen very often, unfortunately for us. Now, what causes syncope? As I said, lack of cerebral perfusion, and usually the blood flow has to stop for, in people at least, for a critical period that goes from 6 to 8 seconds. It mostly depends on the physical activity at that particular time, because obviously if the patient is resting, it may take a little bit longer in terms of interruption of blood flow. But if the patient, the person experiencing syncope is exercising, perhaps a shorter period of reduced cardiac output can be sufficient. We don't know exactly what the critical time is for dogs and cats, but we believe is very similar. That's at least based on our own experience, even if we never did experimental study to prove it. And what are the causes of syncope? For in a simplistic sort of approach, we can divide them in 3 groups: cardiac causes of syncope, vascular causes of syncope, and non-cardiovascular causes of syncope. And you see there is a list of potential causes here under each category that I'm going to explain with real cases. I'm not going to spend too much time explaining this slide. So we will move directly to our cases. So let's start with the cardiac syncope. So cardiac syncope can be caused by anatomical outflow obstruction or cardiac tamponade, or could be myocardial ischemia, although this is less common, much less common in dogs and cats, although I do have an example for you in a dog, bradycardia and tachycardia, where probably bradycardia and tachycardia probably represent the majority of cardiac causes of syncope. And why is that? We look at this diagram and we understand immediately what happens when the heart rate is either too fast or either too slow. So let's look at the sort of range in the middle, which is the normality. You see that with the increase in heart rate, the cardiac output doesn't increase very much. It does increase a little bit, but not too much. And the reason is that when the heart rate increases, and we see the equation, of hemodynamic on the right side, if the heart rate increases, the stroke volume decreases. And the reason is that there is less time during a fast heart rate for the heart to fill properly, for the ventricles to fill in order to pump blood with the subsequent contraction. And therefore, within a certain range, which is the range of heart rate variability in a normal physiological condition, the cardiac output remains the same. But when the heart rate goes too fast, then the heart doesn't have real time to fill with blood. It's sort of vibrating in a way. And therefore, the heart rate, the lack of stroke volumes prevails, and therefore the cardiac output drops. And we can see that sudden decline after a critical point. Deliberately, I didn't put heart rate numbers because it depends on the individual, the species, it depends on the physical activity and so on. So, but just as a principle, when the heart rate is too fast, the cardiac output drops. Similarly, if the heart rate is too slow, then the cardiac output drops because the stroke volume will increase, but can't increase indefinitely. It will increase to the point of maximal compliance. And therefore, when the heart rate drops too much, the stroke volume cannot increase anymore, and therefore we got another drop in cardiac output, as shown here in this diagram. So that's the mechanism of bradycardia and tachycardia in the development of syncope. But let's start with this case. With this first case, we said that there are also outflow obstruction responsible for these problems, and this is one case in this very young cane corso that had recurrent syncope during intense exercise, and on auscultation had an irregular heart rhythm, which on ECG was caused by the presence of several ventricular ectopics. So there were a lot of VPCs causing this abnormal rhythm. And there was also a very loud systolic murmur at the level of the left base. And the ultrasound image, in this case, shows the cause of it. You can see a very thickened right ventricle here on this echocardiographic video. Despite the quality here of the image, you can see that there is an abnormal conformation of the pulmonic valve and turbulence in systole, which is always very suggestive of a pulmonic stenosis. And we can see here in a different projection how the stenosis causing turbulence in the outflow tract. This is bad news, of course, because severe pulmonary stenosis are not obviously a nice condition for the dog, especially when they are symptomatic, like in this case. But there is a condition that we can palliate with a technique called balloon valvuloplasty. We can see here the dilation with this inflatable balloon of the narrow valve that has been opened widely in order to allow a nice flow into the pulmonary artery. This dog responded beautifully to the treatment, to the valvuloplasty, and did not faint since, and had a full normal life since. This is another case of obstruction that we saw a few years ago, well, many years ago, it's probably 20 years ago nearly now, but was published eventually in the Journal of Small Animal Practice. It was caused by the presence of an intracardiac tumor. So this 9-year-old female schnauzer, miniature schnauzer, had lethargy, anorexia, syncope on exercise, and signs of right side failure. The echocardiogram here is quite dated, probably 20 years ago, shows that the mass, which is visible here on post-mortem, the mass was occupying the majority of the right atrium and the right ventricle. And for this reason, there was not enough blood going into the pulmonary artery, and therefore not enough blood going into the lung circulation, not enough blood going back to the left side of the heart, and therefore not enough blood pumped into the aorta, and therefore carotid arteries and the brain, which explains the syncope. Unfortunately, this dog could not be treated, or perhaps could have been treated with open heart surgery, but at that time wasn't available, and therefore this image is a post-mortem specimen. Right, let's move now to the tachycardia and bradycardia. That's an example of bradycardia, severe bradycardia, causing clinical signs in a dog, signs of falling. This dog was not syncopal, but was falling during intense exercise and lethargic throughout the day. 5-year-old male neuter Labrador retriever called Bruce that had a regular heart rhythm at 40 beats per minute. Now remember, for those who are not familiar with electrocardiography or cardiology in general, remember when you find a slow heart rate in a dog and extremely regular, is usually a complete AV block or an atrial standstill. But complete AV block is, at least in my experience, a little bit more common than an atrial standstill in dogs. And therefore, they should immediately raise suspicion of something wrong. So record an ECG if it's available immediately. Here we can see that there are a lot of P waves that are not interacting with the associated here, or non-associated, as you say, QRS complexes. So these QRS complexes, or the ventricular activity, is completely independent. It's like a complete divorce. The atria do not talk to the ventricles, and the P waves beat at their own rate, which should be the physiological rate, and the ventricles try to keep the animal alive by producing their own complexes, in this case probably coming from the junction rather than the ventricular wall, and therefore we have a trace like that. So the only treatment for these cases is the implantation of a pacemaker, and this was my very first pacemaker actually in 1999, I remember, and this was a dual chamber pacemaker, so I decided to start with a difficult one. And so there is a lead that is sensing the atrial activity in the atrium, attached to the atrium. The signal travels along the cable or lead that goes to the pulse generator, which is connected to this side of the neck, and then the pulse generator, so the actual pacemaker, sends another impulse down to the ventricle when the other lead is attached to the wall, and therefore every time we got an atrial activity, we got a ventricular contraction. And you can see the ECG here shows exactly the restoration of the sinus rhythm due to this very efficient dual chamber pacemaker. Now, this is a unique case because I've seen cases like this only once or perhaps more, but obviously never went to the very bottom of the problem probably in the other cases. A 5-year-old male German Shepherd called Toby that had lethargy and occasional falls during intense exercise, and on physical exam had occasional extrasystole. These extrasystole were actually just the tip of the iceberg, because on Holter we found that there were severe ventricular arrhythmias throughout the day. So, but the underlying problem, so I should say probably the problem causing fall in this case, was probably this intermittent complete atrioventricular block that was also seen on ECG and Holter recording. And this dog also had elevated troponin I. Now we're talking about, this case was at least 20 years ago, and we were not very familiar with interpretation of troponin. Now we got much more knowledge, but there was also what we thought was a regional hypokinesis of the right ventricle. So the right ventricle wasn't really moving much. But again, we couldn't suspect anything more than a complete AV block, and therefore we had planned to place a pacemaker in this dog. But the very night before the pacemaker placement, the dog died. And he died in hospital just the night before, and people in intensive care trying to resuscitate completely unsuccessfully. And in the next image, you will see what happened in this dog. This dog had a massive myocardial infarction affecting the right ventricle, which explains both the elevated troponin, explains the hypokinesis, and you see it's almost, you can also see through, the tissue is completely dead, and so it's very, very thin. So try to imagine if we implanted a pacemaker there, then the cable would have gone through the muscle very easily. So in a way, we were lucky that this dog decided to die the night before, otherwise it would have been a dramatic intervention. But you see, myocardial infarction does exist, so we have one case that fills the list that is was reported at the very beginning. Tui was a cat, 4.5-year-old at the time, that had frequent episodes of syncope during the day. And the interesting thing about Tui, that physical exam was unremarkable, the ECG was unremarkable, we couldn't find anything abnormal. And so we recorded a Holter in this cat. I think we were amongst the first to do Holter recording, because this is another case of 20 plus years ago. And that's how we were recording Holters at the time. They were very heavy tape cassette recorders. So it was like a 500-600 grams, this device. A little bit like, for those who are as old as me, like the old Walkman. So now we got the iPods to listen to music, but at that time we were going around with these tape cassettes that were playing the music. Anyway, this was, rather than playing the music, was recording the electrical activity of Tui. And because we couldn't really send the cat home on a Holter, we kept the cat in hospital, and we created sort of umbilical cord here to avoid the cat to chew and damage the device. So let's see what we found on Holter. When Tui was fainting, the heart was stopping. The heart was stopping completely. What we see here is a PQRST, so normal, two normal ECG complexes, and then we got a battery of P waves not followed by QRS complexes. And the very first complex comes approximately after 8-10 seconds. The longest pause we recorded in this case was more than 11 seconds, so certainly sufficient to cause the clinical signs. But even in this case, the only treatment available is a pacemaker implant. And that's what we did. At that time, we tried the transvenous placement of the pacemaker lead, which was very successful. As you can see here, you can see the lead going inside the right ventricle, and we connected the pulse generator under the skin at the level of the abdominal wall. But we found later on that this type of intervention can predispose to chylothorax, because probably the lead had blocked the lymphovenous junction and therefore caused the chylothorax. I'm very tempted, because since my report, because this was published, and since my report, I think everyone in the world was very skeptical of using this technique, so the transvenous technique. But it's also true that leads nowadays are much thinner, so perhaps we should consider this again in the future. Nevertheless, TUI did very well for several months and stopped fainting, and that's certainly at least an initial successful story. Again, very old images here. Another old image of this old-fashioned Holter recorder. But if you know the story of the Holter recording, Norman Holter was the engineer who invented it back in the 60s. The very first recorder was 41 kilos. So 500 grams was certainly an improvement. Now, the Holters we use nowadays are less than 40 grams. So how technology evolves is unbelievable. Now, Oscar was a young boxer that had occasional falling and syncopes, falling and fainting. But again, physical examination, ECG, all unremarkable. And therefore, we did a Holter, and on Holter, we found this surprise. So we were talking about slow rates earlier. Now we're talking about very fast rates. So we got a normal PQST, 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 and then starts with a very fast run of ventricular tachycardia, well above 300 beats per minute. And obviously, when the heart beats too fast, it doesn't have time to fill with blood, and so it cannot pump blood with a subsequent contraction, which explains why this dog was syncopal. Now, in human beings with this condition called erythmogenic right ventricular cardiomyopathy, the treatment of choice is an implantable defibrillator, which was tried in dogs, was actually tried in boxers by some American colleagues, who, however, found serious issues because the algorithm in the implantable defibrillator is designed for people, and it does not recognize the compasses in dogs, in particular in boxing with very spiky T waves. And everything that is above 160, 180 beats per minute is considered tachycardia. So these devices can discharge a very painful electric shock to these poor dogs, even when they're just having a normal sinus rhythm. For this reason, as far as I'm aware, nobody else tried implantable defibrillators in dogs. So what we do instead, we used amiodarone in this particular case, and amiodarone, which is an antiarrhythmic drug with a variety of different activity, but primarily is considered a potassium channel blocker, which worked very well in controlling syncope in this dog. We don't know whether this treatment can prolong life or increase the life expectancy in these dogs, but certainly control the clinical signs very nicely. Talking about ventricular arrhythms in cats, we got here another example of erythmogenic right ventricular cardiomyopathy. Again, this was published in Julius Moreno Practice, again, at the beginning of the millennium, 2002, I think 2003 perhaps. And again, this cat that was having several occasional syncopal episodes had a completely unremarkable ECG, had signs of right-sided congestive heart failure, but completely unremarkable ECG. It was only on Holter, here we can see that he had very short periods of ventricular tachycardia, and or salvo, some people would say, but the cat didn't faint though during the 24-hour ECG. So we assume that perhaps in other days, the ventricular activity was much more severe and sufficient to cause syncope. So you see, if you can if you see the event, the falling event, the syncopal event, and you got ECG abnormality that coincides with that, it's easy assumption, but or it's a confirmation, I should say. But otherwise, we need to work on assumptions that if there is an arrhythmia, but the dog or the cat did not faint during that recording, it is not unrealistic to believe that they may have more severe arrhythmias during other days. So there was these were the cardiac causes of syncope. Let's move to the vascular causes of syncope that, in my opinion, are even more fascinating. And we got a long list of causes here, certainly the most common causes of syncope in people, including the vasovagal syncope or neurocardiogenic syncope and the orthostatic hypotension. And then we're going to see all the others as we go with real cases. So the orthostatic syncope is caused by a reduction of venous return or venous pulling due to a prolonged standing position. We've seen already a couple of pictures of soldiers during a parade that faint and they fall like skittles on the floor. The reason is that these poor guys have to stay very, very still. They can't move in an upright position, sometimes even in summer days when it's hot, and so they're also dehydrated, which doesn't help in the pathogenesis of this problem. But it means that because of the gravity, a majority of blood will sit in the venous bed in the legs. So it's not going back to the heart, and therefore the heart starts being relatively empty, and then there is a lack of cerebral perfusion. There is another thing I said, they need to stay very still, because people can actually learn a technique to avoid fainting by contracting the muscle of the legs alternatively, and that provides a muscular bellow, so a muscular pump that pumps blood to the upper part of the body. The abdominal bellow, so the movements of the abdomen, the movements of the chest, can also improve the venous return to the heart. But these poor guys have to stay as still as possible, and therefore very often they may not have the opportunity to do this exercise to prevent fainting, and they fall like this. There is a theory that perhaps we experience the venous pulling, so the orthostatic syncope, because we're not fully adapted to the standing position. So we derive from monkeys who were in quadrupedal type of standing, and we move to an upright position. And so the body still, despite the several, many millions of years of evolution, have not developed the capacity to win the gravity that is necessary to bring blood from the feet to the chest where the heart is, and then from the chest to the head. So there's a lot of gravity that needs to be taken into consideration, and this may be the cause of this common cause of syncope in people because of this maladaptation. So people may ask, why then giraffes can walk around without fainting? Because they got such a long neck, and the heart is, well, few meters below compared to the head. How can they win the gravity to bring blood to the brain? Well, some people say they got valves and blah, blah, blah. There are no valves in the arteries for sure. The answer is actually much easier than that. They've got a massive left ventricle. So look at the cross-section of the heart of a giraffe. It looks like an incredible hypertrophic cardiomyopathy. And that's how a giraffe can create a very strong stroke volume, a very large stroke volume, and therefore a very important cardiac output that can allow the blood to reach the brain. And it's unbelievable how nature can teach us the pathophysiology of syncope. This is just fascinating. So for obvious reason, orthostatic syncope is not present in dogs and cats, simply because they don't live in an upright position, unless they work in a circus and they try to stay on their back legs. But this is not the case. What we see more commonly in dogs and cats is the neurogenic or vasovagal syncope, which is a little bit complex to understand, but I'm trying to go step by step so we can see what exactly happens. So when we have a reduced venous return, that in case of humans could be because of the upright position, but in our patients perhaps it's due to a tachycardia, for example. If we have a tachycardia, then the heart starts contracting too fast, and there is not enough blood in the catacarpal drops. So what happens immediately? The baroreceptors that are at the level of the aortic arch and the level of the carotid bodies then will sense this drop in blood pressure, will sense this drop in catacarpal, and therefore will immediately activate the sympathetic stimulation with increased level of catecholamines that cause a vigorous contraction of what is already a volume depleted ventricle. So this ventricle starts to beat very vigorously, but with no blood inside. So there's a lot of mechanical strain at the level of the muscle, and there are mechanoreceptors at the level of the myocardium and also the level of the pulmonary artery that will sense these phenomena. And therefore, there is an immediate counter effect, which is initiated by the medulla, which is an immediate high vagal response. So the drop in sympathetic activity, increase in vagal tone. So it's like driving a car maximum speed and then press on the brake very abruptly. And so you get that massive brake, and that's exactly what happens. The heart rate drops dramatically, and then because of the vagal stimulation, you got also vasodilation. So there's also a significant drop in vascular resistance, significant drop in blood pressure. So the vasodilation and the bradycardia are the cause of syncope in these cases. So in other words, in dogs and cats, what we see is a tachycardia followed by a very sudden bradycardia. And we can obviously confirm it on ECG if it happens during ECG recording, which is very unlikely, but more likely on even an event recorder or a Holter recorder. We're going to see all this technology in a minute. So going back to the vasovagus syncope, I've got this example, Tara, dog de Bordeaux, young dog de Bordeaux. You see the brachycephalic appearance of this dog is actually a contributing factor because the brachycephalic breeds tend to have a more pronounced vagal activity. So when it's stimulated, the medulla can give a very prominent vagal activity. So we tend to see this more commonly in brachycephalic breeds, but obviously it can happen in any other dog that is particularly predisposed. And for 6 months, Tara was showing recurrent falls, not syncopal, but falls during exercise. And the physical exam was unremarkable. The ECG was unremarkable, just sinus arrhythmia, 84 beats per minute. So in this case, we used an event recorder that was implanted under the skin of the dog. And that's what we recorded. So you see the dog is having a normal sinus rhythm here, and then it starts getting very, very fast. The dog was getting excited, agitated, and all of a sudden it goes into very severe bradycardia, almost a systole for a period of time. So you can imagine a very sudden drop in blood pressure, and the heart rate was contributing to the clinical signs. You may be able to see a little triangle here. This little triangle here is the activation of the remote control that owners can carry with them, and they can activate the device in order to save that particular ECG. And that's exactly what happened. So Tara's dad found that Tara was fainting, pressed the device at this point so we could see what happened before, what happened during, and what happened after it got a spontaneous recovery. And the sinus rhythm that was restored completely. Another potential cause of syncope is due to a lack of oxygenation of the blood due to, for example, pulmonary hypertension. But pulmonary hypertension is rather than lack of oxygenation, is more likely more of an hemodynamic issue. So the blood cannot go into the lungs, so there's less blood or find resistance to flow nicely in the lungs, and therefore there is less blood going back into the left atrium, so there is less blood that is then pumped to the brain. So in very severe cases of pulmonary hypertension, then we can detect echocardiographically, then obviously there is a risk of syncope. And then don't forget hypobulimia, dehydration. It could be spontaneous or could be caused by environmental conditions like heat strokes in summer when people leave their dogs or cats in cars with temperature reaching very high values, or when they've got like a physiological inverted commas dehydration due to large effusions to the body cavities, like in these massive ascites, or could be iatrogenic. So maybe we are responsible. To give too much diuretics, for example, we can induce iatrogenic hypovolemia and dehydration. And for this reason, the stroke volume is severely affected, and we end up with lack of or a reduction of cardiac output. And then we got other interesting cases that are called the situational syncope or straining during a difficult defecation or urination, or during swallowing, during deglutition, or during coughing. We can have, again, a very pronounced vagal response that can be responsible for the drop in blood pressure and drop in heart rate that will lead to drop in cardiac output. This case, for example, is a case I saw a few years ago. Was a crossbreed with mitral valve disease that was not symptomatic yet, but apart from, so wasn't showing clinical signs of congestive heart failure, but was showing fainting after coughing. And cough was due to, obviously, it's not a congestive heart failure causing cough, but it's the presence of a concomitant airway disease exacerbated by the fact that the heart gets bigger with the underlying cardiac disease. But I did this test. I recorded ECG, which you can see is completely unremarkable. It's a nice sinus rhythm, nothing wrong here. And then I induced cough, and I induced cough by gentle tracheal palpation. And look what happened. As soon as I induced the cough, the dog became severely bradycardic. Didn't faint, but that is a very high suspicion that the dog may have more severe bradycardia or even asystole during other coughing events. So that's a very simple test you can do when you've got dogs that are fainting after coughing. Just do an ECG, and during ECG recording, try to induce cough, and you will see this abnormality that in a way will confirm that the syncope is caused by pronounced bradycardia and obviously dropping blood pressure because it's all vagally induced. And then we got the third group that I mentioned at the beginning, so non-cardiovascular causes. These are not common in our patients, are more common in people. Neurological, for example, very common in, or even the psychological, very common in people due to anxiety or panic attacks, etc. Metabolic, again, common in people due to hypoglycemia. Iatrogenic, that's something we can see, and actually something that I used incidentally in the past using acepromazine. Hydrolazine can also cause drop in blood pressure, amlodipine. So that's something we can see in dogs and cats. And then we got miscellaneous forms of non-cardiovascular syncope. Let's go and see some real cases. The inappropriate arterial dilation is, as I said earlier, is probably one of the most common causes of syncope in people, and usually in the vision of blood is a very common cause. And people may faint when they see blood, or they receive a very bad news and they faint, or something that is causing a lot of emotions, strong emotions, and it's all coming from the cortex. So the cortex is sending signals to the medulla, causing a very sudden drop, a very sudden vagal activity with drop in blood pressure and heart rate. Now, interestingly, in human medicine, there are a lot of patients that faint. There are students, medicine students, that faint during the first necropsy. They see the body, the blood, etc., and the vision of that is so distressing, so emotional, that can cause syncope. And a very famous scientist called Isaac Newton was a medical student. When he went to the first necropsy, he fainted and he decided to leave the medicine studies to become a physicist. And he did pretty well as one of the major physicists in history. And so I'm glad in a way, we're all glad in a way that he fainted and so didn't become a doctor, but a real scientist who changed the way we see life around us. Right, now psychological syncope in dogs and cats is not a real problem, never been reported at least, and is not reported in the animal kingdom at all, with the only exception of some snakes that they play dead, or the American opossum. The American opossum is quite peculiar because as soon as he perceives danger, he pretends to be dead. And obviously for the predator, it's less appealing to eat a dead body than a body that is still alive and that can be eaten afterwards. And we will see here this little opossum sees a dog, perceives this as a real danger, and then faints. It is also true that these animals, the major cause of death in opossum is the road traffic accident, because they cross the road, they see the car coming, they panic, they faint, and then they're squashed by the car. I know it sounds very sad, but that's what happens to them. But let's look at the video. Let's see this opossum fainting. There we go. The dog, you saw the dog, and so it looks like that. The dog sniffs around, no interest in the dead body, and walks away. Now the dog owner goes to reassure the little opossum that looks pretty dead, but there we go. He's now walking, going towards the street, so probably going to be run over by a car and die because of a road traffic accident, poor little thing. Now, in the miscellaneous group, I decided to bring this example. Kojak was, at that time, an 8-year-old German Shepherd. When I was working in the States, in Minnesota, he belonged to the police department of the Edina Police, and he was a hero in the area because of his amazing activity in patrol and narcotic detection. But he became exercise intolerant and was therefore dismissed, and he was then adopted by the police officer that was looking after this lady here. We're still in contact after nearly 20 years, 15 years at least. And she reported the dog was exercise intolerant and looking a little bit dizzy at times, not fainting, but certainly not right. And ECG recording diagnosed a 3rd-degree AV block. And so we decided to implant a pacemaker, which went very well. But when we saw Kojak a few weeks later for a recheck, despite the significant improvement of the exercise capacity, was still having a little issues, was leaning against the wall, or leaning against the furniture, or leaning against the legs of the police officer. And that's because the pacemaker had partially detached. So the tip of the lead was not properly connected. So we had to reposition it, and that solved the issue. I remember this with a smile, because when I said to the police officer, come back so we can interrogate the pacemaker, she looked at me with 2 big eyes, and I said, well, what's wrong? And I explained what interrogation was, and then she smiled. Also, we're going to interrogate with a desk lamp in the eyes of the dog, as we do with the criminals. That was funny. Right, so let's move away now from the cardiovascular condition, and let's move to, so from the syncope, let's say, and let's move to the abnormal and electrical activity of the brain, or seizure. That is another important cause of falling. I shouldn't really talk about seizure. I'm probably the least qualified person to talk about neurological problems, but there are situations where it's not that easy to differentiate between syncope and seizure. So that's why I report these cases here. Obviously, when we see a dog like this, it's pretty obvious that this is an epileptic crisis. which is caused by an abnormal electrical activity of the brain and an altered mental state and an uncontrolled muscular activity that we call fit or convulsion. But as I said, it's not always easy to differentiate between epilepsy, classic epilepsy, and the non-epileptic seizure. So the non-epileptic seizure, in a way, looks more similar to the syncope, and we're going to see examples in a minute. So that's why I always use this picture here, where in the majority of cases we can say, yes, this is syncope, classic, or this is epilepsy, classic, but there are situations where the differentiation is not that easy. And there was a very nice paper published a few years ago, well, a few years, now 14 years ago, but time flies, where they reported the etiological classification of seizures in cats in 91 cases. Of these 91 cases, they had cases of so-called cardiac seizure or convulsive syncope. So in other words, when the lack of cerebral perfusion is very abrupt, very sudden, or when it's prolonged, then we can have tonic-clonic movements like we see in an epileptic dog. This can be induced with a test that I would please don't do it at home because it can be dangerous, or be assisted by somebody. So the convulsive syncope can be recreated in human beings. So basically, what you need to do, you need to press your chest and then squat down and do a lot of sort of squatted movements like this, and then all of a sudden you stand up, and then you got this very sudden lack of venous return, and then the fainting is almost inevitable. But in this video, I'm going to show you the fainting is followed by this tonic-clonic movement. You see, this lady has just fell on the mattress, and she's having this convulsive syncope. They remain unconscious for a few seconds. Here I've got a dog with a convulsive syncope. The dog is actually sleeping, and it's a very poor video quality, but taken with a telephone of the owner. But you can see there are tonic-clonic movements and now a little bit of extension of the legs. And this dog that we got now is much more visible. We never get professional videos done by dogs owners or cat owners. But this beautiful dog, she's a very, very sweet dog, had obviously this problem and was referred to a neurologist. Neurologist, however, because heard a soft murmur, didn't want to anesthetize the patient for the MRI, so asked for a cardiac investigation first. And so what we did, we decided to put a halter in this dog, and we can see that when the dog was having this convulsive syncope, the heart was stopping completely, and this pause lasts for 20-25 seconds. So this is complete cardiac arrest, and that's when exactly the dog was having these syncopal events, this sort of convulsive syncope. Now, the loss of muscular strength or weakness is pretty straightforward. Obviously, if there is no strength, the patient can fall. And we need to be careful because weakness is a loss of muscular strength, but has to be differentiated from myopathy, myasthenia, electrolyte imbalance, hypoglycemia, anemia. And therefore, we need to make sure that we rule out all these possible causes. And there is another condition that I mentioned at the beginning, but I'm not going to spend time because it will sort of jeopardize the content of this lecture, is the exhaustion. And I studied the physical exhaustion in dogs on the treadmill, and I can actually make this comment because it may sound quite ridiculous, because I tried to publish, this was a very high quality study that I did in collaboration with a human physiologist who was actually the scientific advisor of the GB team, so the British team of the Olympic Games. So he knew a lot about exercise and exhaustion. He's probably still one of the most experienced people in the world talking about exhaustion. And I couldn't publish my study in any veterinary journal because everyone said that the study we were doing on the treadmill to bring dogs on to exhaustion which was exactly the same that they do in athletes, in human athletes, so exactly the same. They thought it was unethical, despite I had all the authorization and the ethical approval. I couldn't find a single journal. So it was published in a journal of physiology, one of the high impact factor journals in human medicine, which is, for me, certainly a reason of pride, but not very good, because very few people know that this information is available about exhaustion in dogs. But let's move forward, because there are other situations that can cause falling that are not necessarily cardiovascular, but they are in a way cardiovascular, but they're caused by the weakness of the legs. So look, this puppy, this 10-month Irish setter, is you see very wobbly after a few steps, completely unable to walk, and therefore was seen by an orthopedic surgeon initially, who couldn't find an abnormality and referred internally the case to me. Echocardiography showed a very thickened right ventricle, so immediately we decided to do an angiography. At that time, talking about more than 20 years ago again, this was the standard test, the ideal test to recognize a right to left shunt in PTA. So basically, you see here a right ventricular angiogram. So there's an opacification of the pulmonary artery. So this is a catheter coming from the jugular vein into the right ventricle, and there's the contrast medium injected. And then we did injection a little bit higher, and we see that the blood was going straight into the ductus arteriosus, opacifying the aorta rather than the pulmonary artery. And so that's how we confirm this condition. So obviously, these are not common cases, but it explains how weakness can cause falling in these cases. Muscle cramps is something that I experienced personally several times, especially when I go for a long ride. I'm quite unfit nowadays, but when I go for long rides on the bicycle, then I experience cramps, and very often I can't stand, so I need to lie on the floor until the cramps have gone. And the same applies to dogs. I've never seen a dog with cramps, but they are reported in dogs performing at extreme level, like in these dog races. And because of the cramp is a permanent contraction, or uncomfortable and long-lasting, not permanent, but long-lasting contraction, then on palpation you should be able to feel this sort of knot where the muscle is contracted. But as I said, I can do it on my own legs, but I've never seen it in the dogs. But I thought it was nice to cite it. And similar muscular pain, if there is too much pain in the legs, then the patient may fall. And that's obviously straightforward. Now, let's have a quick look at cats before moving to the diagnostic interventions and how to treat these cases. So let's see what's available in the literature about cardiac syncope in cats. One case reported in the literature, it dates 1998, so it's quite an old study, and reported syncope in a cat with heartworm disease. You can see the white arrows here are showing the adult worms, so these are adult Erythmogenic worms living in the pulmonary artery, causing obviously an outflow obstruction, which was indeed responsible for syncope in this patient. Again, very old study, pardon me, very old study published in 1970, when the cause of syncope in a cat was believed to be a paroxysmal atrial tachycardia. At that time, they didn't have all the recording, and they never managed to prove the coincidence between the arrhythmia and the fainting. But the fact that the cat had atrial tachycardia suggested that there was the cause of syncope. And then there was another study published in '94 of cardiac arrest, as you can see, very similar to the case I showed you earlier, with complete sinus block, sinus arrest, causing a long period of cardiac arrest. And this was a cat with lymphoma and cardiac lymphoma. So the assumption that the tumor infiltration was responsible for this conduction abnormality, and I agree, is very sensible to believe so. This is a case that we saw earlier of TUI, which was published in JSAP in 20 years ago, so meaning that I saw this case probably 22, 23 years ago. And this is an atrioventricular block with ventricular standstill. So basically, when you got an atrioventricular block, you would expect to see regular escape beats, as we saw with Bruce, the black Labrador at the very beginning. When you don't see the regular escape beats, the right definition is ventricular standstill. So in other words, the ventricles do not intervene to save the life of the patient. They do eventually after several seconds of inactivity. And we saw also this case here that again was published in Juno's Moreno practice of a cat with, actually there were two cats, one that had the ventricular arrhythmia and one had this atrioventricular block. And these were both cats with erythmogenic right ventricular cardiomyopathy. This case was published in 2009, and it was a case I saw when I was working in the States, and this was a cat with supraventricular tachycardia. The rate was well above 400 beats per minute, but we're going to see how we reached the diagnosis in this case later on. I've got a sort of summary of this case, which is very interesting. But again, you can see that cases in the causes in cats are very similar to those reported in dogs. Vascular syncope in cats reported with a situational syncope during defecation in a cat, which had also simultaneous or concomitant pulmonary thromboembolism. And then I've got this one. It's got nothing to do with syncope in a cat, but when you Google, when you do a search and you search for syncope in cats, you inevitably end up with this case report published in the Canadian Medical Association, Journal of the Canadian Medical Association. And this was the story of a very fat cat. And this fat cat was, the actual fainting was this 87-year-old lady. The lady was fainting every time this very fat cat, which was 9 kilos in body weight, was sitting on the chest of the poor lady, causing a compression and a very strong vagal stimulus that was causing syncope. So that's why the paper was, the title of the paper was "The Cat Naps an Elderly Woman with Recurrent Syncope." Very interesting story, and very, very beautiful lady with a beautiful smile. And they managed to treat the lady with a pacemaker. They managed to treat the cat with a very good diet. So at the end, both cats and lady did very well. And non-cardiovascular syncope in cats is extremely rare. We don't have the same sort of psychological syncope we saw in the opossum. The metabolic, so the hypoglycemia, is almost impossible to see in a cat. It's also very difficult in dogs. Usually when you see a dog with severe, or a cat with severe hypoglycemia, is because they have either an insulinoma or they got sepsis, but otherwise they got an amazing gluconeogenesis, and they maintain the glucose level much better than we do. So this is just theoretical rather than practical for our patients. Right, so having seen all this massive gallery of cases, I think you got a very good sense of what syncope could be in dogs and cats. So let's move to how we diagnose it. And the diagnosis can be very frustrating, or I should say, used to be very frustrating, because now if the client is prepared to pay for the exams, which are not very expensive anyway, but if they're prepared to pay and they're prepared to go step by step, guided by us, we reach a diagnosis in the majority of cases. Although definitive diagnosis is not always achievable, but that's why I said the majority of cases. When should we start with a test? It's a very difficult question, because very often they have a fainting episode, but then go back to normal, so we got time to organize our test. But there may be cases where the fainting episode could result in sudden death, and therefore we don't want to waste too much time. So we need to have the right choice of sequential tests in the right order. So first of all, we need to have a very good history, and the history needs to identify the presence of potential cardiac diseases, or the presence of or the history of administration of cardiac medications that may affect either the cardiac rate or the cardiac output. We need to find out the number and the frequency of these episodes. We need to see if there are precipitating factors, and like exercise or excitement, for example. We need to understand the type of seizure, the duration of the event. We need to see whether there is a change in the color of the mucomembranes, or if there is a lack of heartbeat. And the funny thing, and I don't know if it happened to you, when you got a syncope case and you sit down with these clients, you ask these questions and they say, I wasn't there, my neighbor saw it, or my wife saw it, or perhaps they come together, husband and wife, and they start arguing. You have to say, how long does it last? I say, well, a few seconds. No, it's a minute. And then they start fighting. It's so typical. So you need to be very skilled when you collect this information from these clients. And if they've not witnessed the event, you need to find a witness, or at least a video recording of the event, which is amazing nowadays. So easy to record an event because everyone has a mobile phone. Pretty much everyone has got a mobile phone with a camera. They can record these videos. Now, a video recording is so important because if you see the video recording before, you can start selecting cases. This one, for example, is not a case of syncope. It was referred for syncope, but if you see this little terrier here, is absolutely fine. And he looks around, he's quite bored probably. And then you will see in a few seconds, it will start showing what the owner described as syncope, what the vet described as syncope, but certainly not syncope. Let's wait another few seconds, and you will see the dog starting. There we go. Right, these are muscle twitching. So in my opinion, this is certainly not a typical cardiac issue. Look again, the dog is resting. And in a few seconds, it starts. So for me, this is more a neurological problem. So you see, a video recording can perhaps give direction on where to go in terms of diagnostic tests. But also don't remember that sometimes it looks like syncope by epilepsy, or it looks like epilepsy and it's syncope. So we need to take that into consideration. Now we got a video of a more convincing syncope. This is a very old video recorded with a camera. I remember the owners went to buy the camera positively to record this video. Again, a case I've probably seen more than 20 years ago, and that's what we see. A dog, the stuff is running beautifully, super happy. The owner is still learning how to use the camera, as you can see, and regains control of the zoom, and the dog, meanwhile, has slowed down. If you look carefully, the dog is now looking very disorientated, and then it goes down and it looks completely dead. Unfortunately, we don't have the rest of the video when the dog recovers, but you also need to understand how distressing this situation is for the carers, and therefore the first thing they tried to do was to do a cardiac massage to avoid death in this patient. But I can promise the dog got up after, woke up, and came to see me the week after. Now, if we have one of these breeds, German Shepherd, or a Boxer, or a Doberman, which are particularly predisposed to ventricular arrhythmias, perhaps we should focus more on the rhythm and perhaps consider a 24-hour or 48-hour on the event recorder to determine whether or not they have an arrhythmia. But obviously, we need to perform a thorough physical examination, making sure we do a pretty complete cardiovascular examination, paying attention on the color of the mucomembranes, the pulse quality, the heart rhythm, and so on. A basic neurological examination to see if there is any evidence of a deficit of the cranial nerves, so deficits of the central nervous system, or even the peripheral nervous system. as well as assessment of the musculoskeletal system with the proper manipulation of the limbs. If everything is normal, then we can move to additional tests. In human medicine, that's why you need to be a little bit careful when you read syncope from a human textbook or a human publication, because in people, they tend to do the tilt table testing to see whether there is any vasovagal type of syndrome, of syncope. So in other words, they start recording ECG and blood pressure with the patient horizontal, in a sort of horizontal position on the table, and then the table is lifted a few degrees per time up to a sort of vertical position. And so if there is predisposition to vasovagal syncope, these patients faint during the test, the blood pressure drops, the ECG, the heart rate drops, which is very similar to what we saw earlier. You remember the young girl that was standing up suddenly and then falling. That's exactly so. They move slowly, but they go from a horizontal position to a vertical position. And you can see this patient here that is now still talking, look, and then all of a sudden, 1, 2, 3, gone, fainted. And therefore, when this happens, they record the bradycardia and low blood pressure. They return the patient to a horizontal position. The recovery is usually very, very rapid. You see, these nurses are actually quite relaxed. They're smiling. Probably they've seen this happening hundreds of times. And that's why when you've got somebody fainting, the very first thing to do is to ask them to position them horizontally on the floor and lift their legs to favor the return of blood to the heart using the gravity. Tilt table testing is completely useless in dogs and cats simply because they don't live in an upright position. Somebody tried to measure blood pressure and ECG by doing this maneuver, but it's completely meaningless because there is no way that a dog or a cat will live their life in a standing position unless they work in a circus, like in the old picture here on the left side of the screen. How about lab analysis? Do we need any particular test? I think that for this particular problem, for syncope, we don't need very much. We need to make sure that the patient is not severely anemic, so hematology or even a PCV can be helpful. We need to make sure there are no electrolyte imbalances. We need to make sure that glucose is not too low, like in case of insulinomas, for example, or sepsis. And then I always recommend to measure creatine kinase, because if there is a significant myopathy, CK, AST as well will be elevated. So a very basic blood profile can help dramatically. ECG recording is a waste of time. Obviously, if we can hear the arrhythmia, if we can detect the arrhythmia on physical examination, absolutely, let's record an ECG. But otherwise, it's a very low diagnostic value. Although it's relatively inexpensive, I would not even bother to record an ECG in these patients. Echocardiography, the same. It's not very useful. It might be useful if we hear a murmur at the same time or a gallop sound that may suggest the presence of a cardiomyopathy in a cat, or an arrhythmia that you can see on echocardiography, or if there is a familiar history or predisposition to heart disease. In these cases, of course, an echocardiography can be recommended, but otherwise, what really matters is the prolonged ECG recording. Nowadays, we can do 24-hour, 48, 72. We've got a system in our hospital. We can go up to 2 weeks of recording with our Holter system. And obviously, you need to use a bit of common sense, because if it happens every day, Holter recording is great. But if it happens once a month or twice a year, then probably even a 2-week Holter recording is not the best option. This is, for example, an external event recorder. Is used like a Holter. You attach it to the patient with self-adhesive electrodes. But again, these self-adhesive electrodes don't stay attached very long in dogs. They don't tolerate this for the best for many days. So I think that 72-hour recording is probably the maximum we can achieve. And if the event is not that frequent, probably not a very useful test. That's why we have now implantable event recorders. These are amazing because they're very little tiny devices. It used to be bigger, but now this is the actual size. It's smaller than a small memory stick. And they can be implanted under the skin, and this will record ECG up to 3 years. And the owner of the fainting patient can walk around with this remote control that can be kept in the pocket, and if an event is observed, they can press the button and they can save the loop of that particular event. So we can see what happens in terms of ECG before, during, and after the event. The device itself can actually record automatically, so you can set to save the loops for heart rate below 40 beats per minute, for example, or above I think the maximum is 180 beats per minute because they are human devices. But otherwise, you've got this sort of manual option that is fantastic. And then you can retrieve all the information with a pacemaker program, with a scanner. So it's a radio signal, so you don't have to remove the device. You just talk to the device and you can see what happened during the event. So these event recorders have been validated both in dogs and cats. This validation study in dogs was done, that was probably 15 years ago, 2010, 12 years ago was published. So yeah, and I did with this Italian group of Santilli and company. And we found very amazing results here. You can see that this is a dog with a VTAC that progresses into torsade point and then goes into ventricular fibrillation and death. And unfortunately, this is one of the cases where, yes, you get the diagnosis, but you lose the patient. And this is a bit of a lottery. We never know which of the event is going to be the final one. And that's why the choice of the right test has to be done at the right time. But then we had cases of vasovagal syncope, like we saw with that Dog de Bordeaux at the beginning called Taran. And I've got here the story of Benny, which I showed you briefly before. And it shows you the power of this test compared to the traditional Holter. Basically, Benny was 11-year-old when I met him. But since he was a little kitten, it was only 18 months, he started having these syncopal events very frequently, 3 weeks apart. And despite all the tests that my colleagues did, this cat never had a definitive diagnosis. Everything was negative. All the physical exam, blood tests, ECG, chest x-rays, echocardiogram, blah, blah, blah. And the clinician somehow sort of thought about a tachycardia very correctly, because that's exactly the final diagnosis, but had this sort of premonition and treated the cat with atenolol. But the cat kept fainting despite the atenolol, a little bit less frequently, so was fainting every 3-4 months rather than 3-4 weeks. And so they increased the dose of atenolol, but Benny was still fainting, perhaps 2-3 times a year. So again, every year, after every fainting episode, was coming back to the hospital to have the test, including the Holter recording that was completely unremarkable. The Holter didn't show anything abnormal. And when I saw the case, I had already experience with the reviews that I experience that I acquired in the United Kingdom, but at that time I was working in Minnesota, and so I decided to implant this device. At that time they were a little bit bigger, the reviews, they were slightly bigger, but certainly not impossible to implant under the skin of a cat. And certainly I'm a very lousy surgeon. I can do interventional cardiology, but in terms of traditional surgery, I'm not that good, but certainly good enough to implant one of these devices to explain how easy the technique is. And then this is the setting. So the device was set to record automatically asystole, bradycardia, and tachycardia, more than 230 beats per minute, and also was set with 3 manual recordings. And that's the ECG trace after implant, which was showing a nice normal sinus rhythm. And then a few weeks later, Benny then collapsed again. And we found, after activation by the owner of the device, we found that the cat had a supraventricular tachycardia at 400, I think it was 420, 430 beats per minute. Certainly fast enough to cause issues. And that's why we decided to treat this cat no longer with atenolol because it wasn't really working, but we tried a different beta blocker with also potassium channel blockade activity. And with sotalol, this cat did so well that for years never experienced another fainting episode. Then I left the United States, so I hope that Penny live for many years after. Now, this is a case we saw more recently, it was last year, September last year. This cat was also fainting, and was fainting always after a stressful event, and usually was a cat fight. It was a bit of a troublemaker, this cat. Well, he's still doing very well. And that's the reveal implanted under the skin. That's the reveal interrogation. The activation of the reveal. And that's the interrogation done with the programmer. So you can see that's the heart rate. And the heart rate here is sort of baseline here. And then it has a cat fight. And it goes very, very fast. Right, it goes to about 300 beats per minute, and then it suddenly falls, and that's when the cat experiences fainting. And again, these are relatively benign forms of fainting. They don't respond very well to pacemaker implant, and therefore, in this case, we recommend just to try to avoid stressful events. So they try to keep the cat in at night and to avoid fights with other dogs. Right, so there we go. So if we have a fainting patient, the best thing to do is to collect a very thorough history and making sure that we obtain a video recording whenever possible. And then remember a very thorough cardiovascular examination from a physical exam point of view, basic neurological examination, and then a basic blood test as I briefly described earlier, and then ECG or echo, but only if there is a real reason for that, because if there are no arrhythmias or particular reasons to do an echocardiogram, they're not going to give us any particular information. So we need to consider advanced ECG recording, and if we have one episode or more than one episode per day, then we should try a 24-hour ECG. Or if it is 2-3 episodes a week, we can use a 48 or 72 hours ECG. So basically, we can consider these ambulatory event recorders. But if it is less than once a week, then I would certainly recommend an implantable loop recorder. They are expensive, yes, they're very expensive. Probably here in the UK, we're talking about £2,000 for a brand new device. And the good news is that we can't use brand new one either, because we don't find every time the insured owner that would like to go ahead. But there are on eBay or on various auctions, you can find devices that are about to expire, or they're already expired, but the expire date is because of the sterility. So you can re-sterilize them in ethylene oxide, and you still have a device that can record ECG, maybe not for 3 years, but for 2.5 years, certainly possible. So that's something they can certainly consider. And if it's a cat, you do exactly the same, pretty much, right? And then you can still record a halter in cat. You can consider an ambulatory ECG recording or an implantable loop recorder. So what happens if we, with the event recorder, we detect an arrhythmia that coincides with a fainting event? Then we can consider the appropriate treatment. If it's a bradycardia, whether we can implant a pacemaker, or we can treat a tachycardia with radio ablation, or we can treat with antiarrhythmic drugs. So there are several options. But if, despite the fainting event, we don't see any arrhythmia, that's perhaps more likely, in the absence of any other clinical signs, of course, without a murmur or a gallop rhythm, etc. So assuming that there are no cardiovascular abnormalities, then we can consider referral to neurology, which is more expensive, more invasive, because most of the time what they do a CSF tap, they do an MRI or electromyography, and most of these tests require general anesthesia, and therefore they are a little bit more invasive and more expensive. But that's pretty much my approach nowadays, and it's a very similar approach to human medicine, where they need to be very efficient in terms of costs, especially in public health, and therefore the correct series of interventions is very similar to the one that I've just demonstrated. And this is my last slide. I hope you enjoy this gallery of cases of falling and fainting, and I believe we have time for questions. I don't know, but perhaps Daniela can tell us more how it works.
Thank you, Luca. I'm totally fascinated by your talk. So you managed to keep a surgeon attached to the screen and listening to a topic that has nothing to do with surgery. Is amazing what you do, what you guys do with every time I listen to a cardiologist to talk, like last time we had Kieran, now we have you. So I just realized how much I don't know about cardiology. So it's really amazing.
But you know how to hold a scalpel blade. I don't. So that's
that's not true, because you have just shown how you implant one of these the implantation. So anyway, it's not fake what I'm saying. It's really, I'm fascinated what we could do nowadays with with the cardiology and with all the technology as well. So we need to wait to see whether we have questions. I think there is another guest for you. Today we have many guests and many surprises.
I'm really moved.
And I would like to ask Paolo if we can let the new guest join us in the live.
Ah, Claudio!
Claudio, you are on mute.
Claudio, il microfono. Accendi il microfono.
Daniela recommended me to shut off the microphone, and so at this time, at this hour, usually I'm sleeping. So, but
my God, because it's 11:45 in Italy.
I'm an early morning person, and usually I sleep at this time. But anyway, I enjoyed the lecture. It was very good, very useful, I think. So I think the use of the video now, it changed our life, because owners almost have the cellular phone in their hand, and they can document very easily. Let me ask a question, so it's a sort of statement suggested. You showed a nice video on reverse PDA. I saw this dog walking with a rare limb, the weakness of the rare limb. I think it's important to recommend to all cardiologists to use, of course, if you are already in the fluoroscopy, you do the catheterization, but to document the reverse PDA, the bubble study, is so good, so easy, and it works so well. I think we should recommend that.
Absolutely. We actually did a bubble study in the dog, but wasn't 100% clear. At that time, actually, I was still a resident, and had Peter Dark working with me, and he was said, let's go to angiography. He loved angiography so much. I mean, Peter very well, and Peter started doing angiography well before echocardiography, so for him was a sort of must, and that's how we detected absolutely nowadays a bubble study. For those who don't know what the bubble study is the injection of an agitated saline with microbubbles in the cephalic vein, and then you follow the abdominal aorta, because if there is a reverse PDA, these bubbles move from the right ventricle into the pulmonary artery, straight through the PDA in the descending aorta. You see the bubbles going down. It is actually beautiful to see. And I wouldn't.
Luca, I am glad you mentioned Peter, because he was my first mentor in the 86. In the 86, I was a student. I was working with him, and when John Bonagura was on his sabbatic, and the two students with us was Katie Moores and Virginia Luis Fuentes. They were students. So you know how much I'm old. But anyway, that is not the point. Let me give you a suggestion. In Human, I learned one lesson. I've done a lot of bubble study because of PFO in Human. And in Human, you know, PFO, you have to close. When I was doing my residency in cardiology specialization, I was closing PFO almost every day. The best way to do the bubble study is to take two syringes, a three-way stopcock, use 5 millimeters of saline one side, 5 millimeters of plasma expander, take 1 milliliter of blood, mix together. It comes out something pink, horrible to see, but anyway, it works. And you see bubbles, so a wave of bubbles, so like the fog in London during winter, something like that, very white. And it works very well. Anyway, thank you, Daniela, to invite me. We were so happy to see you.
Thank you, Carlo. For me, it was such a beautiful surprise, but also an honor, because perhaps people on the other side of the screen don't know who you are. So Claudio is probably one of the most eclectic cardiologists, because he's not just a veterinary cardiologist. He was first a veterinary cardiologist, but then he became a human cardiologist as well. So he works with human patients and veterinary patients with the same ease, and it's just amazing. You're an inspiration for all cardiologists in the world.
I'm just back in the vet medicine. You can tell that I learned practicing human to treat animals.
That's
so
very
if I'm allowed to say, a little bird told me that you are in Sicily now.
Yes, exactly. You see my time.
God.
I'm here because I'm completing my cardiology book. I hope it will come out this year, because this is the last chapter.
Yeah.
And so officially I'm here writing. Really, I'm going on the beach, enjoy the seaside.
We envy you, absolutely.
Yeah, but on Sunday I should go back in Milano to work. We are going next 2 weeks. We have other 2 mitral valve repair. With the new
when do you
Yeah.
Sorry, when do you do that?
We are going to do some mitral valve repair using the V clamp, which is transapical treatment of mitral valve.
Yeah.
It's working. I've been in Bristol 2 weeks ago.
Yeah.
To do that with Kieran Bogart.
Yeah. Mm-hmm.
Worked well. I think it's a very difficult procedure.
Okay.
But it works. Of course, we are still in a learning curve to understand what kind of patient we can treat.
Yeah.
What kind of patient can be successful. I got today several documents of many dogs with mitral insufficiency. Many of those is too late to treat. They have completely disruptor of the valve leaflet. And so we need to identify which are the right patient to treat. But the amazing things, we are not aware about the long distance result, of course, because we are starting. But what is amazing that after the procedure, 4 or 5 hours later, the dogs walk.
Yeah.
Walks and goes around, because we do very, very mini thoracotomy. We do transapical puncture. We use a 14 French introducer, which is not small, honestly, especially in 5 kilogram dogs. But anyway, they tolerate very well. And that's a great difference compared to cardiopulmonary bypass.
Yeah.
We used cardiopulmonary bypass in Milano for some other cardiological procedure, so like tricuspid dysplasia or some VSD that we cannot close percutaneously. But it's days and days of intensive care. It's not easy for these poor dogs. I would say that definitively hybrid cardiac surgery or interventional cardiology is anyway the best solution for human and for dogs. Anyway, there is not the ideal solution. There is the right solution for the right patient. Of course, surgeons want to cut and open as much as they can. Interventional cardiology they would like to work like people who does the boat in the bottle, and you can put from a small hole. Anyway, I think we need to be honest and choose the right patient.
So, despite I'm a surgeon, I'm very fond of the interventional procedure. So I'm an atypical surgeon. I don't like blood, so
I don't like. This hybrid procedure. It's the real hybrid procedure, because we talk hybrid procedure anytime we try to do a mini thoracotomy. But the real hybrid room in human is something quite important. Yes. And we are trying to be less aggressive. It's not just an exercise, just to make a patient living better after the procedure. Yeah. Look at in human cardiovascular surgery, there are so many procedures that have been already substituted. They are treating by transapical or transcatheter tricuspid insufficiency, functional mitral insufficiency, because mitral clip work only in functional mitral insufficiency, aortic valve, pulmonary valve. We are doing so many procedures. Of course, we need to do our best for our patient in any way, in any manner.
It's interesting because I've asked Kieran if he wanted to. I was thinking to do like a round table with you, Kieran, Luca, and Dan Brockman, because Dan Brockman with the mitral valve repair. It would be really great to put together all the opinions, because, as you were saying, the selection of the patient is very important, and those were your interventional approach is not indicate, then very likely these patients are the ones that would need mitral valve repair surgically, I think. Yeah. So, but maybe the numbers of the patients needing surgery will be less if you manage to do it with an interventional procedure. Do I see well, or I'm completely wrong? So
no, I think we are still learning, and the alteration of the mitral valve is so complex. And also, we don't have to forget that really we are in some way fighting against nature. So it's a degenerative disease. Or you substitute completely the valve, but that's a completely another story. And in my opinion, in dogs, it shouldn't work, because there is a problem of coagulation. So many cardiovascular surgeons, experimental cardiovascular surgery, have tried. Me too, I worked with them, and they developed thrombi. We put many mechanical valve in dogs. They have coagulation problem, they create thrombi. Even biological valve, it's not so easy. And if you put a clip, a V-clamp, you made an annuloplasty, you made a repair like the style used by Miami Oashi, so the Japanese group, they put neocorde, they put an annuloplasty, or they don't, because really if you watch the case, generally they don't. And the important is to put the neocorde, which is some synthetic new cordy, tendine, and you have to do the annuloplasty. Or you put a ring, or you restrict the annulus with 2 stitches in the 2 sides. Anyway, it's a genetically determined disease. The disease is progressing. So, really, what do we give to these animals? 1, 2 years?
We buy some time.
their destiny is to end his life anyway. It makes sense. The dog we treated a couple of weeks ago was a typical Cavalier Chinchals of the bloodline that developed cardiac failure at 6 years of age. So this dog was a huge left ventricle, but was a young dog. We put this kind of device. The day after, he had an almost normal left ventricle because he was young, because decreased the mitral regurgitation. But honestly, if we put this device in a dog 12 years old, it makes sense. I'm not sure.
Okay.
Because they have a life expectancy which is limited anyway. Most of these dogs we treat medically, and they have almost the same life expectancy. I think we need to be honest to select the patient. Now everybody asks, oh, okay, you repair the mitral valve. Okay, let's go. We repair all the mitral valve. Most of them, they have the right medical treatment, and they can live 14, 15 years. That's it. Look at how many of these dogs you have seen living with the medical treatment, living together with the mitral insufficiency. Of course, it's not for a Cavalier King Charles, which is already in cardiac failure at 6 years of age. That makes sense.
Totally agree.
So there is a certain the discussion here is also about ethics, no? In what we do.
Exactly. It's ethic at the same time when you decide that this dog needs surgery or this dog needs an interventional procedure. And you need to be ethical, not because it's like a restaurant. If you sell fish, you don't sell meat. If you sell meat, you don't propose meat, fish, or what else. I propose what is right to do. Yeah. I've done some, for example, PDA closure in cats. Yeah. But only when they have a huge PDA closure cat with coils, but only when they have a huge ampulla, which is too dangerous to close surgically. Otherwise, a surgeon can do a better job because it takes a lot of time to get the femoral artery. And maybe I work for 2 hours. A good surgeon takes 20 minutes to close a PDA in a cat. Yeah. So it's honest to do that on this way. And I will let in the end of a surgery because it's correct. I think it is a sort of malpractice if you have available an interventional cardiology to close a PDA in a German Shepherd 50 kilograms. If you have the unplaster, it takes 15 minutes to close. So we need to be honest. And to be honest, to propose any medical treatment, not because you like to do that.
Can I go back to the reverse PDA? So the reverse PDA is not a surgical candidate, right?
Oh, absolutely.
So you treat it medically?
I treat medically. I think in human we have one protocol which is called a treat and repair. We've been proposed by if I'm right, I don't remember because I'm thinking about the literature. It's been proposed by a Swiss cardiologist called Bighetti, which is an Italian name. And they say the protocol is treat and repair. You have a patient with reverse PDA. You give sildenafil. You measure the pulmonary vascular resistance. You measure the pulmonary vascular resistance after 6 months. If the pulmonary vascular resistance decrease, you may treat this patient, so you stimulate the pulmonary vascular resistance with oxygen during the procedure. So after the repair, you can treat this kind of condition surgically. It works only in the slide. In the slide of the presentation, it works. In the real world, it doesn't work. You know why? Because when you have the overflow during the reverse PDA and the early age, because the reverse PDA is not a disease of the adult age. It develops in the first month of life. The overflow, everything happening in physiology is determined to survive. It's created by the evolution of the species. So if you have a huge PDA, or you die for a pulmonary edema in the first month of life, or the pulmonary arteries do not remodel after the birth, remain with a structure, a muscular structure. But this muscular structure necrotize because of the overflow. So degenerate. There are 6 levels of evolution of this structure of the pulmonary capillary, precapillary structure. In the reverse PDA, it's almost the end stage. They have sort of disruption. I don't remember exactly. I don't have the English for this. But anyway, it's a disruption of the artery, which is irreversible. Really, this dog, you never get back even with sildenafil in a condition to be treated. But on the other hand, most of the dogs, especially the small dogs, not the big dogs. The big dogs do not tolerate well reverse PDA. But small dogs, Chihuahua, Maltese, sometimes poodles, but mostly Chihuahua and Maltese. Now they are on fashion. At least in Italy, there are a lot of Chihuahua and Maltese with reverse PDA. They live very well because they have a systemic right ventricle. So the right ventricle is very hypertrophic. So the circular fibers of the right ventricle become very thick. They develop and they have a radial function, and the right ventricle is able to tolerate for many hours, for many years, this high pressure in the pulmonary artery. So they do not tolerate exercise, but usually a Maltese or a Chihuahua live in a bag, doesn't live in the world, in the real world. They stay there, and they stay there very well. I had a Chihuahua Maltese that at 10 years of age. You give sildenafil, they don't show any reduction of the pulmonary hypertension estimated by transvenous regurgitation, but they feel better. You know why? Because they have improvement anyway of the cardiac output. Because you still have right elevated pressure in the pulmonary artery, but the cardiac output, because of the sildenafil, is improved. So they have better saturation. They feel a little bit better. And they live with sildenafil for many years. So it's not so bad to have a reverse PDA in a big dog, in a small dog. In a big dog, it's different. Why? Because that's my theory, but I wrote that. Because you have a larger ventricle, and because of the Laplace law, you have a bigger radius, increased wall stressor, and the right ventricle goes in failure much earlier, and probably they exercise more. We had several border collie and Doberman with reverse PDA. They die at 4 or 5 years, no more. But Chihuahua, they live 10 years with reverse PDA.
Okay. Claudio, thank you so much. It was very, very interesting in all the stuff you have to tell us. We have some questions that we Luca, can you read the question? This is from Adam.
Yeah. Before I answer in Adam's question, I would just like to say thank you to Daniela, Carla, Tammy for the nice comments. Thank you very much. Much appreciated. Right, Adam, that's a very good question. In the vasovagal syncope, the use of a pacemaker is very controversial. The reason is that you might be able to control the bradycardia with a pacemaker, but you cannot control the vasodilation that is caused by the vagal stimulus. Therefore, you never get 100% result with a pacemaker. I did occasionally implant pacemakers in these dogs, probably in a handful of cases maximum, and that's when the cardiac pause was so long on all the recording that I was concerned about the potential risk of sudden death, and I was concerned about the possible damage to the kidneys due to the sudden loss of cardiac output. And in these cases, we did see a response, but it's never a full response. So they can still faint, but to a much less degree and less frequently. So it has to be chosen very carefully, but even in humans, it's never the first line intervention. And usually just avoiding if it's possible, to avoid the trigger of the vagal response, like excitement, for example, especially in brachycephalic breeds, they can prevent the syncope. The use of a sympathomimetic, I would say no, because that would be for life, and you can't really keep a dog on a sympathetic stimulation for the rest of his life. So I would say no to that. Pacemaker, very selected cases.
I have a message for you, Luca, from Dan Brockman, who is in Austria. He says, please tell Luca that Peter Modler and I wish him and Heidi the very best and look forward to catching up with you soon.
Oh, that's very kind, very nice. I really look forward to meet all these people.
Yeah.
Because with COVID, even with Claudio, we haven't seen each other for years.
Yeah.
We're going to meet certainly in October, Claudio, but perhaps the CVM. Are you planning to go to a CVM in Gothenburg?
Yes, I should.
Right, so we will meet there and have a few drinks together.
Okay, for sure.
So here, Mark Overend. Thank you for the donation, Mark. Hi, Luca. I missed your comment on exercise-induced collapse in Labradors. What is your thinking on this now?
Mark, thank you very much for your comment. And again, Mark is another person I haven't seen for years, but hopefully with the post-copy will be easier. So basically, with exercise-induced collapse, I discovered, but we need another 2 hours to go into detail. I discovered that you can induce collapse in every healthy Labrador. So it's not just Labradors with the genetic mutation of dynamin 1, as reported in the literature. Because I exercised on the treadmill 16 Labradors during my study, and they all collapsed. They all lost control of their legs simply because of exhaustion. So I think that what people call exercise-induced collapse is just a pure physiological response to exhaustion, which is what you see in marathon runners, but the elite runners. I'm not talking about the rubbish runners like me. I'm talking about the elite runners. Sometimes they arrive 1 or 2 meters from the finish line and they collapse. And the reason is because they exert much higher than the others, they will consume all their resources and they just go into exhaustion. This is beautifully explained in human medicine. It's been explained only in this paper, but again, as I said, I never managed to publish in a veterinary journal because they didn't want it. They thought it was unethical to run dogs to exhaustion, but it's a physiological condition. But if you go to the journal of, I think it's Journal Comparative Physiology, which is more of a human journal, it's all described there.
Nice. Any other question, Paolo? This is nice. I cannot pronounce.
Todor from Bulgaria. Todor is actually a very, very experienced cardiologist. I've seen images produced by Todor that I'm so jealous of the echocardiographic images they can obtain. And so if I'm an inspiration for you, Todor, you're an inspiration for me. So let's inspire each other.
So we do want to inspire each other, all our vets and all colleagues with this.
And Carla and I did a few interventions together. I still remember that pacemaker in the Westie when he decided to arrest. We didn't have any temporary pacemaker, but she was amazing. She was doing anesthesia. Then she said, no, when the dog is intubated, you don't have to worry about anything. And she was right. We managed to get the dog back and the pacemaker worked beautifully. Thank you, Carla.
So this is, we have from Philadelphia, and I had the name of this colleague from Philadelphia. Let me just check because wait a second. It's, oh yeah, where is she? I don't find her anymore. No. Jessica Gentile Solomon.
Oh, Jessica, bless you, Jessica. Thank you very much for your comment. Jessica, if you're still online, I've got another cardiologist is joining me. You want to say hi to everyone and Claudia?
Good evening. Hi, Claudia. Good to see you.
Oh.
Wow.
Jessica, thank you very much. I mean, obviously, I mentioned the COVID paper. I think I did earlier, and it was quite a surprise to see these cases. But we've been very, very lucky to be working with probably the best virology team in the world, based in Montpellier, in France. The same team that isolated Ebola virus for the first time, and described. They worked a lot on human virology, and without them, we couldn't have isolated the virus at all. So the big thank goes to Eric Leroy, the head of the lab in Montpellier, who's one of the most incredible virologists I've ever met.
Hi, Daniela.
Daniela, thank you very much.
So I don't see any other. Hi, Erika. Thank you. I don't see any other questions, but I have a question, if I can, from my surgical experience. So I mean, this is for all you free guys. So I'm talking about epicardial pacemaker in cats. Which is your experience?
Yeah, as I said earlier, I reported a chylothorax with the endocardium, and that was in 2000, so more than 20 years ago. And because of that, if you read all the other papers published stuff on epicardial leads, they'll say we decided to go epicardial lead because of the reported chylothorax with endocardial lead, which was all my fault. But nowadays, we are using much thinner pacemaker leads. So I'm pretty sure that the next pacemaker will try again the endocardial lead, because I think the problem was the actual size of the lead that was blocking the lymphatic junction with the vena cava. And I suspect that with smaller leads, the same leads they use in infants, they got very young children, they undergo, and Claudio can correct me if I'm wrong, because obviously it works in the human field as well. They undergo pacemaker implant, it's still done with endocardial leads. So I think we should try again.
Claudio, do you have an opinion on that? Or?
About endocardial pacemaker or about epicardial pacemaker?
Epicardial pacemaker in cats or not?
No, I have no experience in epicardial pacemaker in cats. In children, in small children, of course, is unused. Is used to put epicardial pacemaker. It's easy or rapid to treat, but I haven't treated many cats, and I don't have any experience in placing pacemaker in cats.
Okay. I'm just.
We had a list last year with like 3 in a row.
I think the other thing to say, we recently...
You are the feline cardiologist in absolute.
We recently implanted an endocardial lead, in right ventricular lead, in a very, very small dog. It was a 2 kilo dog.
Yeah, that's a good point.
And that was without complication. 1.8 kilo dog, and that was a routine jugular venous implantation. So it may be possible, like Luca says, that now with these small leads, that the smaller patients may be able to tolerate that. So it's worth trying again, I think.
So basically, the choice between endocardial and epicardial is based on the dimension of the patient, and because there is a risk to occlude the cranial vena cava with the cave. Okay, I understand. Okay.
Like, since we did this dog, I don't know how we managed to do it. Probably I was on drugs that day, because it was the tiniest dogs I've ever done. It also had 3 legs, wasn't it? And we managed to introduce the lead in the jugular vein. There was only 1.8 kilos. So if we did a dog, we should probably be able to do cats.
So now 4 kilos and 5 kilos.
I have no personal experience, but with some American colleagues I've been talking, they have done many endocardial pacemaker in cats. Maybe those were Maine Coon, big Maine Coon, I don't know, but
yeah. So I think we should start again.
Yeah, absolutely.
In children, it makes sense because they grow up, and of course, it's better to put an endocardial pacemaker that you can remove and don't let the catheter inside the subclavian and the vena cava. They get taller, but it's a cat. It's already an adult.
Yeah.
Perhaps it's better. Yeah, I don't know. I've no experience personally.
Which with the endocardial, the pacemaker would be in the cervical region, yeah? The machine itself.
No, it's in a cat. It's more, at least in my experience, what I do, I make a tunnel. I make a tunnel on the back, and I put the pacemaker behind the scapula.
Okay.
Because the lead is too long.
Okay.
It's to avoid to do many loops in the neck.
Okay.
So I would prefer to make a tunnel. I use an introducer, a vascular introducer. I make a tunnel. I bring the lead on the other side, just under the skin, and then I place the battery on the back.
Okay. Okay, so I think we don't have any other questions. I think it was an amazing night. I have strange concepts of an amazing night, but anyway, to me it was very, very useful. I've learned a lot with you guys. I just wanted to anticipate the next webinar, which will happen on the 26th, Wednesday, 26th of May, and this time we will have Romain Pizzi. Romain Pizzi is another amazing specialist, and this time he is a specialist in wildlife, and he will bring us I have the suspect that it will be again another spectacular presentation, a spectacular webinar, and this time is on the vet roles and perspectives in conservation. So Romain treats all possible wild animals that you cannot imagine. So we will not talk about dogs and cats on Wednesday. We will talk about gorillas, tigers, and all this kind of wildlife animals. So I'm really looking forward to it. Paolo, can we go back to Luca, Heidi, and Claudio? Here we are. So if we don't have, I guess we don't have any further questions. I just would like to reiterate to donate, please, because again, tonight has been a really an amazing night, amazing talk. Thank you, Andre, for your comment. And if you have enjoyed this, if you have enjoyed spending with us, basically nearly 2 hours and 15 minutes, just click on the link and donate to help the colleagues and the brothers and sisters in Ukraine, because they still need us. www.justgiving.com/Vets4Ukraine. And with this, I would like to thank you, Claudio, for joining us. It was really generous to give us some of your time. And so you should
just apologize for my long talk, but it was stimulating and provocative. It was a great occasion to make this surprise to my friend.
Look, if you have time, you are very welcome to hold your own webinar. So if you feel that you want, so we would be very delighted to have you here with us. Even because cardiology seems to be a topic that interests a lot the vets, any kind of vets. So please, you are very welcome, Claudio, if you want to join us, so we can WhatsApp later. And Heidi, Luca, it is such a pleasure to see you again. So I don't know when was last time that I met you in person. So I'm very happy that I saw you again today, and I thank you for your participation, for your support in this campaign, and hopefully, we will go ahead and raising funds for Ukraine. Thank you so much, and good night. Good night, everyone.
Okay.
Bye. Bye.
Bye.
Bye.
Look at this, a tunnel of trees. It's like living in a fairy tale. So beautiful. Look at that. behind these hedges. It's just the most beautiful nature you can imagine. I just feel so privileged to be here today on my bicycle, looking at this gorgeous scenery. Priceless. Now tell me if there is anything more beautiful than the English countryside. In a beautiful sunny day like this, it's just unbeatable. See, that's what I want for the future, for my children. I just want a world beautiful where people can get on well together. They can live in peace and harmony. We don't need wars. We don't need this nonsense. And I just think about these poor people suffering right now under the bombs and the attacks. It's just unbelievable. So this is just a praying away for a better world. And we're going to meet on Monday night to talk about falling and fainting or syncope in dogs and cats, which is one of my favorite topics in veterinary medicine. And I'm going to tell you what I learned over the years about how to approach these challenging cases. And I hope to see a lot of you tomorrow online, and I hope there will be a lot of generosity from people to support our vet friends in Ukraine. And so this is my message from today, and love and peace. Ciao. Hello, good morning. Hey, I see what's behind you. Oh, look at that. Hello. Hello, little one. Oh, beautiful. Is your mom jealous? Hello, girls. Hey. Look how beautiful you are. You're a very, very curious girl, aren't you? Come here, sweetheart. You're so beautiful. You're so beautiful. You're so beautiful. Oh, look at your girls. You're the other friends. You're all jealous. You see how beautiful this world is.
It's Sunday night, and we
just need to reiterate the quote from Bob Geldof years ago, which was, "Give us the bloody money."
yeah, okay, maybe. Okay, give us the bloody money.